Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling the comparison between RA and OA. So that's rheumatoid arthritis and osteoarthritis. Before we really break down what's going in both and what makes them different, let's kick it off with our practice question, and we will circle back to the correct answer at the end. Okay, a nurse is reviewing the assessments of clients with chronic joint pain. Which finding would be most consistent with rheumatoid arthritis? We have A, knee and hip pain that worsens with activity and improves with rest. B, brief morning stiffness lasting about 10 minutes that resolves with movement. C, symmetric swelling and warmth of the metacarpophalangeal and proximal interphalangeal joints with morning stiffness lasting over an hour. Or D, hard, non-tender bony enlargement of the distal interphalangeal joints without redness or warmth. Okay, think it through. You're thinking about findings consistent with RA, but if you don't know yet, don't worry, because we are diving into the comparison. Of course, you guys know by now to understand that. First, we really need to talk about the anatomy and what is going on in a normal joint. Okay. Imagine a normal synovial joint as a tiny, perfectly engineered ecosystem. Basically, you have two bones whose ends are covered with smooth articular cartilage. And that cartilage is like a cushiony, Teflon-coated surface. It is like the Pam cooking spray I'm going to put on the baking sheet before I make cookies. It is coating those bones and allowing them to glide over each other without any friction. Okay, so maybe a better analogy would have actually been like WD-40. Now, surrounding that is the joint capsule and lining, and the inside of that capsule is what we call the synovial membrane. The synovial membrane is kind of like the bartender of that joint. It is making the synovial fluid. Now, that synovial fluid is slick. They compare it to egg white-like liquid, but it's the WD-40. It's that lubricant. It's going to lubricate the joints, nourish the cartilage so that those two bones can come together, but they can slide and glide and not have friction. Now, don't forget that around all of that, we got a bunch of stuff. We got muscles, tendons, ligaments. That is all providing stability so we can have movement. And when that movement happens, all that synovial fluid and cushioning makes it nice and easy instead of bone just grinding on each other, causing friction. So first, let's look at how that anatomy goes awry in osteoarthritis. The main problem here is mechanical wear and tear on that articular cartilage over time. Years and years of use, especially our weight-bearing joints, knees, hips, and the spine, or heavily used joints like the hands, they slowly wear down that smooth surface. Kind of like, you've got your favorite pair of shoes and that tread has gradually rubbed off over time. That's the cartilage. The cartilage is rubbing off. It's thinning. And when it does that, the underlying bone is exposed and starts rubbing against the bone on the other side. And bone is not designed to be a friction surface. It responds by remodeling, which can cause things like subchondral sclerosis, where the bone under that cartilage gets denser and harder. It can cause osteophytes, little bone spurs that form around those joint margins. That whole process there, it is local to that joint that is wearing down and degenerative. So it gets worse and worse over time. Osteoarthritis is not systemic. It's not inflammatory. I think of it as very mechanical in feel, all right? It gets worse with use and improves with rest because we are literally, the more we are moving and putting weight on those joints, the more we are wearing down that cartilage, the more bone on bone, and that just hurts. So the joints can be a little stiff, they can be a little inflamed, irritated, or mad, but all in all, a big takeaway for you here is osteoarthritis, OA, mechanical, happens over a long period of time. It gets worse the more we use it and improves with rest. It is not an inflammatory disease. What is the rheumatoid arthritis, the RA. This is an autoimmune condition. The immune system, which, should be defending us from like infections and stuff, it turns on us, autoimmune, self-immune, and in RA, it starts attacking that synovial membrane that we talked about. Now, why on earth does this happen? Wouldn't we love to know? We don't fully know exactly why RA happens. We do know there's like a mix of some genetic predispositions, some environmental triggers. It is a complex process, but once the process starts, the immune system puts like a giant red target on the synovial joints and says, this is where we are going to attack. We get T cells, B cells, inflammatory cytokines, various interleukins. They swarm in to that synovium and start their attack. So what happens from there? Well, the synovial lining starts to thicken and become hyperplastic, almost like weeds in a garden that have gotten overgrown. They are inflamed and proliferating. They've got this destructive, puffy tissue that is growing over the articular cartilage and secreting enzymes that break down both the cartilage and the bone. Now, it can also extend into surrounding structures. So the ligaments and tendons that provide stability over time, this tissue, all this inflammation, all these enzymes can literally eat away, erode the cartilage, erode the bones, destabilize the joints. That is why we are going to have some classic joint deformities that will be a dead giveaway. Hey, this is RA, not OA. Things like that are going to be ulnar deviation, a swan neck deformity, and boutonniere deformities in the finger, okay? When we see those, we are not thinking, that this is osteoarthritis. No, this is a degenerative disorder caused by an immune-mediated systemic response that is eating away at the joint, okay? Immune-mediated, systemic. Those are some key words I want you thinking when you think about rheumatoid arthritis. So let's hone in a little bit actually on systemic. The inflammatory cytokines that are going to the joints, breaking things down, they circulate throughout the body. That's systemic. Your whole system is involved. So it can cause other systemic signs like fatigue, low-grade fevers, weight loss, anemia. You can also have involvement, they call it extra-articular involvement, basically just like things going on outside the joints, like lung issues, vasculitis. In the worst cases, we can have cardiac involvement, okay? Because again, system-wide inflammation affecting the whole body, rheumatoid arthritis. Now, honing in clinically here, I want to talk about a few of the hallmark features. So we already talked about the classic joint deformities. I'm going to repeat them again. Ulnar deviation, swan neck, and boutonniere deformities. You hear any of those buzzwords, you better be thinking rheumatoid arthritis. But another one, maybe even more common for you to hear on like a test or NCLEX question, is prolonged morning stiffness. Basically, when you've been still all night, that inflamed synovium stiffens up and the joints feel like they are full of cement. We will have clients that tell us like, hey, it takes me over an hour before I can even move my hands. Once the blood flow increases, like they get a little fluid going in those joints, then they start to loosen up a bit. But that morning stiffness is very specific to rheumatoid arthritis. Why are we not going to see that in osteoarthritis? Because that's mechanical. that gets worse the more pressure, the more weight, the more we are using those joints. And did we really use them a whole lot overnight while we were asleep in our beds? No, not a whole lot. So osteoarthritis, you should feel your best in the morning. And then as you use those joints throughout the day, they get worse and worse. It is very different for rheumatoid arthritis, where we've got this systemic inflammation. We were still overnight. That inflammation really ate away at our synoviums. We wake up and our joints are stiff. They feel like concrete. We can't move. Morning stiffness, rheumatoid arthritis. Worse throughout the day, osteoarthritis. Another big comparison point, remember, rheumatoid arthritis, systemic. So if we're seeing fever, we're seeing that inflammation, that fatigue, all of those things, you're affecting your whole system. We are thinking RA. OA, not going to have those systemic symptoms. And then one more point of comparison before we move on to treatment is with that RA, we've got those classic signs that we have those joint deformities where the enzymes are eating away at the joints. Those are ulnar deviation, swan neck, and boutonniere deformities. They're going to be warm and squishy because we've got all that heat from that inflammation. Think flame in the middle of inflammation. That's why you're going to see that warmth. But with osteoarthritis, again, this is very mechanical. We have things breaking down with more weight over time. So there are two different deformities that we can see, Herbertine nodes and Bouchard nodes, but these nodes are hard and bony. They come from that bone on bone. They are not warm and squishy like we see with the inflammatory situation going on in RA. So how we treat these, obviously, is very different. Even though they are both arthritis, we see the cause is entirely different. So obviously the treatment will be too. With rheumatoid arthritis, the goal is not just pain relief, it is turning down the immune system fire, before we just permanently eat away and destroy at those joints. So the primary treatment for RA is going to be something called a DMARD. That stands for a disease-modifying anti-rheumatic drug. And primarily what I have mostly seen is methotrexate. Now, it does not work overnight. It can honestly take weeks to months to see that whole benefit, because what it's doing is trying to change the immune system response. It's not a pain med. It's just not just like masking the symptoms over here. It is truly trying to get to that root cause. If you look at the name, disease modifying, it is trying to change that disease and take away that immune system response on the synovium. Now, methotrexate does come with some side effects. We have to do regular monitoring of our labs. LFTs are liver function tests primarily, as well as CBCs. And then usually they will also be put on a folic acid supplement to reduce the side effects like mouth sores and GI upset. Now, like I said, this is going to take like weeks to months to hopefully modify that disease process and kind of stop eating away at the joints. So it is appropriate to hopefully treat that inflammation and pain in the meantime. I mostly see clients put on a steroid taper, something like prednisone to get that inflammation down quickly while we wait for the DMARD to kick in. And then an NSAID like ibuprofen or naproxen for symptom relief. We're going to do a lot of teaching about safety, signs and symptoms of infection, since that DMARD, methotrexate, can suppress the immune system. We talked about putting folic acid potentially for GI upset, but with the NSAID as well, we're at risk for ulcers and GI bleeding. So we want to really look out for that. And overall, probably the biggest thing I'm going to emphasize as the nurse is adherence and follow up with those labs, making sure we're taking that med daily, doing gentle range of motion, trying to get up and walk and move. We want to keep that motion while balancing rest with low impact activity. So we're not like jumping on trampolines and going to run on the mountain trails. But gentle walking, swimming is a great one for arthritis, osteo or rheumatoid arthritis. Those are the types of things we are going to educate as the bedside nurse. But med-wise, you're thinking DMARD, maybe a prednisone taper, and NSAID. Okay, so with RA, remember again, systemic, we're destroying those joints. We're going to give that DMARD to stop that disease process. Obviously, very different for osteoarthritis, because remember, this is mechanical. This is about, over years and years, we have broken down. We've now got bone on bone causing friction and then pain. So we are focused on that mechanical support and managing that pain. We're not trying to suppress their immune system. What we're going to do is weight reduction, physical therapy to strengthen the muscles around the joints, and then meds to support the pain are going to be your tried and true. Your acetaminophen and your NSAIDs are first line. You do want to do cautious with those NSAIDs, right? If you're older, if you've got GI ulcers or GI bleeds, we want to, take that into account. We also want to do the same sort of education on activity. Rest, use assistive devices, do low impact activity as able. We don't want to have complications of immobility, so we want to stay active, but we want to keep it low impact. So osteoarthritis, mechanical, we're going to focus on that support and pain management. Rheumatoid arthritis, systemic autoimmune response, we are going to dial down that immune system. Okay. Hopefully that compare and contrast did the trick and you guys are feeling good. Let's circle back to our practice question to see if you've got the right answer and you know why. You're reviewing the assessments of 4 clients. Which client is most consistent with rheumatoid arthritis? We have A, knee and hip pain that worsens with activity and improves with rest. B, brief morning stiffness lasting about 10 minutes. It resolves with movement. C, symmetric swelling and warmth of the metacarpophalangeal and proximal interphalangeal joints with morning stiffness lasting over an hour. Or D, hard, non-tender bony enlargements of the distal interphalangeal joints without redness or warmth. Which finding makes us think rheumatoid arthritis? Think about it. Maybe you knew it from the get-go. Maybe this is all new info. It is C. Having that symmetrical involvement, seeing warmth and redness. That's making me think inflammatory right there. And then we see that morning stiffness lasting over an hour. That is classic for rheumatoid arthritis and represents an inflammatory autoimmune process that is targeting the synovium. I would not expect morning stiffness over an hour with osteoarthritis. I would also be less likely to have symmetric involvement, and I wouldn't expect that warmth from that inflammatory response. D had hard, non-tender bony enlargement. Non-tender and non-warm, those nodes, the Herbertine and the Bouchard nodes, those are more typical of osteoarthritis because it's mechanical. It's not that systemic problem. Knee and hip pain that gets worse and worse with activity, that's osteoarthritis. When we have brief morning stiffness, that's osteoarthritis. That resolves quickly as we wake up and kind of shake it out. That's not how it goes with rheumatoid arthritis. With RA, we're thinking systemic, autoimmune, symmetric joint involvement, that warmth, that bogginess. We might have those systemic symptoms like fatigue and fever, and that hallmark sign, that morning stiffness lasting over an hour. So hopefully, takeaway for you guys, you were able to kind of differentiate between the two. I know I always got really tripped up on the names because I just kind of put them under one bucket of arthritis, but clearly they are super different. So if you walk away with one thing, hopefully you can remember osteoarthritis, we've got mechanical. It's going to be, over years, over time, you're going to be best in the morning and get worse throughout the day. Versus rheumatoid arthritis, we've got an autoimmune systemic situation going on. We are attacking those joints. So we get that really horrendous morning stiffness lasting over an hour. We get our systemic symptoms. We get that warmth from the inflammation, and we really, to treat it, need to use those DMARDs to dial down the immune response. That is the difference between OA and RA. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.